Hey, Brett, you know what time it is?
No, what time?
It's Miller time.
Love that.
So we sat down with the one, the only Mark Miller. So Mark he's the OG, one of the OGs when it comes to the McKenzie Institute and MDT. And he spent literally years with Robin. He tells some insane stories about some phone calls he had with him, and just what a cool guy.
Yeah, I think, Scott Bowie's been so influential for Gestalt. Mm-hmm. And, we had really never sat down with Mark. We've done a lot with Scott. So it was good to kind of hear from Mark. So we've already, done quite a bit with Scott, but then talk about like how those two work together to basically create the extremity program for MDT. Okay. And, that was, and then also just to see him, as he worked up patients, and then his knowledge base of the information is the most practical I think I've ever heard. Like, he just has a really good way and a gift for putting his words together and teaching. And then the other, thing where he is basically turning the world upside down right now is in the IMC model, which is where instead of in our profession, we're basically financially rewarded by seeing a patient more. In the IMC model, it's the first time where a patient is actually given a case rate, which basically means you'd be given, let's say it's a low back case, you'd be given $1,000 and you can treat them one time or you can treat them 20 times. It's up to you, but you're actually motivated to see the patient less, which that's never happened before. So, and I'm not saying there might not be problems in that also, but I'm just saying it's a different perspective. And for those of us who are in rehab and evidence-based care, to actually be motivated by seeing the patient less, that's probably not a horrible thing.
No, probably not horrible. Now, this is part one of a part two, two-part episodes. And so part one, we dive deep into his story with Robin and MDT and McKenzie, his early beginnings. And the second one is basically all about IMC, the issues with the healthcare model right now and how it all started. And to say that there is some insane stories in this would be an understatement.
And yeah, a little birdie had told us that he liked Schaefer wine. So going to Total Wine and not being able to pull it off the shelf and them saying, oh, we got to get someone to unlock that bottle. I knew we were in trouble, but I got to say, I think that the Schaefer wine that we had, which I can't remember the one we had, it kind of lived up to its reputation. It was smooth.
We backed it up with a little Chapelet too.
That's right.
So it was just amazing. But we're eternally grateful for the MDT model. And I think everybody probably knows where it stands in the Gestalt model, right? The things we're still contemplating is, they may just do an MDT exam and send them home with just an MDT corrective, whereas we're going to try to blend in the MDT with manipulation, with DNS, with these other models of rehab. And so it's not that one's right or wrong. We feel like we're maybe getting patients better that they may not, or other things like that. But man, oh man, is MDT the most powerful thing in the world? So,
well, I think that the safety too is built into a progression of forces. Whereas. And of course I'm a homer for MPI and you are too, whereas we've already kind of through our joint play, that safety, we feel like we can use more force probably sooner than a true MDT, practitioner could. And, so I think that might be a little bit of a difference, but again, that's where I think your MPI background is so critical also. And it really does. It marries really well with the principles of MDT. And, I think that all kind of got exposed in the podcast.
Awesome. All right, guys. We'll enjoy this and stay tuned for the second episode. So have a good day. All right, everyone. Welcome to a new episode of the Gestalt Education Show. I'm Taylor Premier here with Brett Winchester, and we are really excited to be with Mark Miller. So Mark Miller is the Chief Clinical Officer for IMC. He's also an international instructor for the McKenzie Institute, and he won't quite admit it, but he literally wrote the book on the extremities when it comes to the McKenzie Institute.
He's an icon.
Don't listen to him.
Yeah. So we're excited to be sitting down to be learning from Mark. And we're enjoying a couple of really good bottles of wine. Can't wait to. So, Brett, you want to tell them the first bottle that we're having? Oh, I get to do it. So it's Schaefer Hillside Select in 2015. So I've never had Schaefer before. Have you?
First.
So what a great bottle of wine. And then we're going to follow it up with a little Chapelet at the end. So I promise as this podcast gets going, the better it'll get. So well, anyway, Mark, let's kind of start off with tell us your your journey with McKenzie. Where did it all start? How did you first hear about it, and how did you get into it, and what grew your love for it?
Sure. Well, okay. I think the first thing to say is listen, I don't like doing this kind of stuff, but I'll do anything for wine. All right?
It's for a free t-shirt.
That's exactly right. And again, these bottles are great, guys, and I appreciate it. So I don't even know where to start. I can tell you this. I was doing a preceptorship, which was what we call them now. At that time, it was just a placement, clinical placement. And when I arrived there, the two women who were going to be my CIs, they had the week and before they had taken McKenzie Part A, and at that time I think there was a McKenzie Part A and B, and that was it. And I walked into the office, and they introduced themselves, and I said, "Hey, how you doing?" And they said, "Look, here's this little book." And at that point, there was a little blue book that Robin had written, and really it was just a manuscript of his 45,000 patients worth of experience. I'll tell you a story about that later. But they said, "You got to read this because this is what we're going to try to do." I said, "Well, that works for me." And I took the book home, and being the kind of guy I am, I read it about 13 times over a period of a couple of days. Well, the interesting thing is, I was there to learn from them, right? But they were learning something new. So think about how this all worked out. They'd read the book once, and I read the book 13, 14 times in the first week because I was a student. And so by about the second week, we're in the clinic, and they'd come, "Hey, Mark, what do I do? Because there's this guy," and I was doing the press-ups, and his leg got a little numb, and I was just wondering, like, what did it say in the book? And I go, "Well, that's on page 46, and what you got to do is you got to pull the hips off center." So it was kind of like that, and it was really entertaining. Well, the problem is, because I was a little thick at the time, I left there, and I thought, well, this McKenzie stuff is so easy. Obviously, it's not the answer. And so I went back to school, and I did my thing. I didn't pay a whole lot of attention, really, to the MDT experience that I'd had. I just kind of left it behind, went back to school, finished my exams, and moved forward from there. Well, then I get into private practice. Well, it wasn't private practice initially. I went and worked for the hospital up in Northern Ontario, Canada. And what happened was, I'm there, and I'm practicing, and the only real thing of all the things I learned throughout my education that was giving me any results that made any sense to me was this MDT thing, which we didn't call it then, we called it McKenzie. And so I started thinking to myself, what the heck is going on? And so I kept working at it, and I started getting more and more frustrated because I was only so good, and then I didn't have answers for the rest of these patients. And so at that time, I was living in Northern Ontario, so I was working under a Ministry of Northern Affairs environment. So what that meant was this: you sold your soul to the Ministry of Northern Affairs. Just like in America, you join the Army to get your education paid for. Well, I signed on for 2 years to live above a certain parallel. And I didn't realize when I got up there, except for the money they gave me to do it, that there were certain advantages. Now, so to most of your listeners, they're going to go, "Oh my God, that guy was born in 1881." But I got to tell you, at that time, you actually had to go to the library. You had to find the journal. You had to actually pull it off the shelf, and then you had to read it. And if you could convince the librarian to let you use the photocopier, you could actually photocopy it. That's how we got the articles. Well, living in Northern Ontario, what I could do is I could call down to the University of Western Ontario, which is our country's best medical library. And because I was an outreach clinician, they would do it for me. So what I did was I took McKenzie's little textbook, and I sent them the list of 196 articles that he referenced in his book, and I got them to photocopy every one of them.
Microfiche.
No, that's exactly right.
Wow.
And I had them send them up. And I did the same for Syriax's textbooks, and I did the same for what everybody else was doing out there, because I was flailing in the wind. And if they didn't get better with extension or with retraction extension, I didn't know what to do. So anyway, I get all these articles that I'm reading and I'm learning and I'm developing, and I get to a point where I go, you know what? I'm not going to do this anymore, because I'm not finding the answers in musculoskeletal medicine. And I'm watching all these people coming in, and they're getting x-rays, and they're seeing orthopedic surgeons, and no one was getting an answer. So I thought, you know what, this musculoskeletal thing is kind of screwed up. But the only place I was getting results, and by the way, when I analyzed all these articles, the only guy that was telling the truth that I could tell in their textbooks was Robin McKenzie. Let me explain that. So if he quoted an article and you read the article and then you went back to the quote, son of a gun, the article supported what he was saying. But in a lot of these other textbooks, they would quote these articles around these statements, and I would read the articles, and the articles, if you dissected them, that's not really what they were saying. And I thought, oh, at least this guy's honest. So guess what? I'm out. I can't do this. Problem was, I had 2 degrees and I didn't have any money. Right? So I'm thinking, oh, you're going to go back to school? How are you going to explain this one? Right? There's only so many hours at McDonald's that you can, punch in. And so what I did was I wrote McKenzie a letter. And I said, hey, what are the chances of me coming to spend some time with you? Because I'm thinking of getting out, and I think you might have something, but I don't know. And of course, I got a couple of letters back. They go away, kid, you bug me, kind of thing, right? But in one of the letters he sent me was, but keep trying, keep doing some good work. So then I hit the jackpot. I get this phone call from the University of Western Ontario's library, and they go, we don't know who you are and we don't know what you are, but we've never had to work as hard. We are photocopying constantly, and it's all about the spine. What are you doing? And so I said, well, I'm trying to learn. And they said, well, guess what? There's this outreach program that goes through across Northern Ontario, and it's a well, they don't call them podcasts. I think they were telecasts or something. You get on the phone and people would call in, and that was the technology at the time. They said, could you do something on the spine around literature? And I said, yeah, I'm glad to. So about a week before it was going on, they said, look, not only physical therapists, but chiropractors and physicians and surgeons, they all want to get on this. We put it out there, and it's about low back pain, and it's a big thing, and it's gone countrywide. Would you still do it? And I'm thinking, yeah, it's no big deal. I'm just going to tell them what I know. It doesn't matter if it's right or wrong. It's just, I've read these articles. This is what it says. So I do this. Well, I'm thinking to myself, after I get done, I go, oh, I bet you that McKenzie guy would go for this. So I wrote him another letter, and I said, hey, I want to come to New Zealand, and I've done this and this and this, and son of a gun, I get a letter, and he says, come on to New Zealand, I'm going to pay for it, and I'll train you. So that's what happened.
Wow.
The reason I went was because I was going to watch him examine, I was going to try to learn from him, and if he didn't have the answers, I was done. I was done with physical therapy, I was done with orthopedics, I'm not doing it. I'm going to do something else because it's too screwed up. And I watched him in the clinic for 2 weeks, and I thought, oh, he's got the answer. Science doesn't say he does. Nobody else says he does in Canada. But I'm telling you right now, I know it. I just knew in my gut. I just knew it. So that's how I started. That's what happened.
And what did you see in those 2 weeks, Mark? Like, what was it that just opened your eyes to, the wonder of Rob McKenzie?
What I realized is he did not. It's not that he didn't care. He was a lovely, lovely guy. But his intent was not to fix anyone. His intent was try to understand. And the way he tried to understand was not, here's the anatomy, so let me stress the anatomy and then figure out what that anatomy is. It was, whatever's in front of me has behavior. And if it is truly an orthopedic condition that I can actually have an opportunity to try to resolve, I got to understand that behavior, regardless of what the anatomy is, regardless of what the mechanism of injury is, regardless of how old they are, regardless of what their story is. There's got to be, it's a cause and effect relationship. And if I can find that, I can continually use that cause and effect to devise a methodology by where I can help these people. And as I sat and watched it over and over and over again, he was more interested in understanding it than he was in fixing it. And so it's kind of like what he kept doing was he kept analyzing and analyzing and analyzing and analyzing, and then the problem went away. It wasn't, let me see what this is, now I'll devise a treatment plan. The treatment plan never sort of surfaced. It was just, he continued to analyze, and the more he analyzed, the more he saw the cause and effect relationships, and as they changed, he kept changing what he was doing. It took me a while to figure it out, but as I was watching it happen, I was thinking, oh my goodness, I get this now. Kinda. It took me a couple of years. I went back to Canada, and he had actually asked me, you know, Mark, and he liked me, and I liked him, and we, you know, it was kind of cool. But he said, would you teach this? I said, yeah, all day long, except for I don't know what I'm teaching, and I don't know how to do it, but yeah, I'll give it a run, right? And but the point I'm trying to get to was the thing I did realize: if you just follow the cause and effect, and whatever happens, it creates a question, and then you develop a mechanical methodology by where to try to create an answer. That's how I started getting successful in the clinic, and I learned that when I watched him, and I knew it. I knew he was right. Now, I didn't know if the rest of society, the medical societies would accept it, but I knew he was right, and I decided to stay in musculoskeletal medicine. That's how it happened.
They always say, Mark, principles kind of stand the test of time. So it sounds to me like, even, I don't know, you didn't date it, but I don't know how long ago that was, but I mean, how much has MDT evolved since then? Or have the principles basically stayed the same? What would you say about that?
I think our evolution is, and Robin always used to say this, he goes, look guys, I've kind of scratched out the surface and I want you to take it from here. And, you know, we always chided him like, okay, you're being too humble, and that's not true. But there's an essence to what he said. No, he didn't just scratch the surface. I mean, he gave us volumes, right? I mean, remember I told you about the little thin book?
Yeah.
So I remember asking him, I said, Robin, you got to tell me, how many patients did you see before you wrote that book? And he goes, well, Miller, it was about 45,000. I kind of chuckle, I go, 45,000? How did you pick 45,000?
How old are you?
And he goes, I said, how did you pick 45,000? He goes, oh, well, I thought that'd be about enough.
That was the key number. I love it.
And it's kind of, there's some truth to this, right? So that's all it was. It was his experiences, and what he did was he just kept paying attention to every variable. And then he would do like what we would now call a regression analysis. At that time, he just kept every data point on everything, and then he started to realize certain data points had value and other data points didn't, right? So I forget your question, by the way, and I'll do this.
That's all right, we'll regroup. But I mean, I think our listeners have heard, you know, multiple speakers talk before, like Bobby Fischer is the best chess player. Mm-hmm. He called it like building memory traces. Another way to say it would be like pattern recognition,
right.
You know?
Yeah.
So it seems like all the greats in the world, it doesn't matter exactly what your discipline is, they're really good at like paying attention. And it sounds like Rob McKenzie was one of his gold medals, is kind of knowing.
No, absolutely. He paid attention to everything, but then his other talent was recognizing those data points that counted, and then stringing them together, right? What I learned from watching him, and again, a lot of this stuff I would love to tell you, I knew it immediately. I saw it, and he taught it well. You had to kind of watch him, and then you had to kind of get it by osmosis, right? And if you asked him a question, he'd teach you, but you had to know which question to ask. And at that time, I was like, I didn't know what question to ask. I just kind of watched it all happen, and I saw it, and I kind of figured out, well, I'll go back and try it. And I really do believe it took a couple of years. I mean, I was on stage teaching courses, and I look back now, and I didn't know what the hell at all what I was doing. But it still made more sense than the other things that were out there. So it's kind of like one of those things. You were still, when you were in front of 60 people, you were still, because you could examine a patient and use cause and effect analysis to make decisions, you were still ahead of everybody. Mm-hmm. You know what I mean? Yeah. So it was like that. And so he had so many great talents, but one of them was to pay attention, and the other was to change his mind. He could have an idea in his head, and he could have an anatomical basis for that idea, and then something would happen in the clinic. He'd go, no, that's wrong. I'm wrong. And he would let the patient teach him. But his talent was being able to extract the information. Like he said, Miller, every patient knows they don't know they know. And the ones that don't know have it within them, they just don't know how to figure it out. And he goes, and my job is to just get it out of them. So that's where one of the great things I learned from him was the history. Like, let's take the better worse section. I'll never forget this. We were sitting in his office and we were just talking, right? Because I really just enjoyed picking his brain, and he loved giving you information, but you had to draw it out of him, right? And he said, what are you thinking about that better worse section on the form? And I said, you know what, I'm not sure it helps. Like, sometimes it distracts me. And he goes, I wouldn't mind seeing it just be a big blank. what makes you worse? What makes you better? And then take it from there. And I always thought that was really cool. And by the way, it took me about 10 years to finally start doing that.
We've talked about how obnoxious it is. Well, how's sitting? How's standing? How's walking?
Well, some of us are a little thicker than others, right? So it took me a little longer. But, I eventually figured it out.
Yeah.
And of course, we have to have standards within the institute. And frankly, there are a lot of like there are tons and tons and tons of clinicians that can't think for themselves. Right? And it's just the way it is. And so he's like, okay, how do I help these people the most? He gave them the best questions. But I can tell you, the people that do this best, they ask the patient, tell me what makes you worse, and then show me. And that's the thing. I always make the joke. I always try to, as soon as possible, I try to take my patients to Missouri. And then people kind of look at me and they go, what's he talking about? And Missouri is the show me state. Right? And it's like, show me, because as soon as you show me what makes you worse, and I watch you and I watch how you do it, I probably will know what's wrong. Because there are those conditions that rapidly reverse and rapidly change. We call them derangements. And then there are all those others that don't. And there's a whole series of them, and I'm not going to get into it. Let's not bore your audience. But bottom line is you watch somebody, when you ask them, do you know what makes you worse? And they say, it means they don't. Which means most likely it hasn't healed this way.
How often I've learned with my mentors, like as time goes on, and a lot of times your mentors, they're deceased at this point, that you think about something they said, and then like in hindsight, you're like, oh my gosh. Like, but at the time when you heard it, it didn't mean much to you, but then you're like, okay, this makes a lot of sense.
Yeah, are you kidding me? That happens to me all the time still. You're so dead on. And it's funny, so many of the things he said, maybe he said them on purpose, maybe he didn't, but I can tell you this, I didn't get it at the time. And so here we are having a glass of wine, and I can tell you, you are going to bring something up that's going to remind me of something that maybe Robin said or one of the other early on mentors in this area, and I go, oh, shoot, I haven't thought of that, and I just learned something today.
Mark, you have to tell our listeners the story you told today about the knee derangement and how you thought you were really onto something, and then I think really how Robin handled the whole thing is just, I mean, you talk about an icon. The way he even handled that and what he told you, if you could maybe tell us that story.
I'm going to give you two. All right, I'm going to give you a 2 for the price of 1 here because I think this is important, because I think what you're asking me is, can you kind of help the people that are listening maybe understand Robin a little bit better or get to know him a little bit better? So the first one is this, and this is funny. So I get back to Canada, right? I'm up in Northern Ontario, and Robin wants me to go out and start teaching some courses, and I'm thinking, man, I better get good at this, because I'm going to be seeing 10, 12 patients on stage in front of my peers, and not all the peers are very happy to be there, and not all the peers are going to agree with a lot of things we say. And by the way, at the time, we didn't have a whole lot of science behind things. We had Robin's book, and hey, how you doing? I'm Mark Miller. I'm from Southern Ontario. And so the patient, I got to see patients, a lot of them, before they're going to start paying attention to what I got to say. So anyway, I get back to New Zealand, and I'm really working hard. I'm in Canada. I'm working hard in the spine, and I get this, and I got a surgeon who's a buddy of mine. Right, we play golf together. We go for a couple of beers once in a while, and so he's like, I'll send you all your spines, but you got to take care of these post-ops for me. And so he's sending me these knees and things, and I get this one guy, and resolve his knee pretty quickly. Great surgery, easy rehab, no problem, right? The next guy, same everything, and he's a mess. I can't straighten the goddamn knee out. I can't get anywhere with it. And I'm doing all the stuff that at the time we did. We'd sustain it. We'd put hot backs on it. We'd sustain it more. We'd mobilize it. We'd try to manipulate. We did all these things, right? And this guy, nothing's happening. And I'm getting frustrated as heck. He's taking up a lot of my time. I'm wasting his time, and I'm thinking, So then I go, you know what I'm going to do? I'm just going to give the guy the dysfunction model. I need you to do this 10 repetitions. I want you to do it every 2 hours.
3 months.
Yeah, and I don't want you to bother me ever again. Right?
See you in 3 months.
Exactly.
You're going to be a lot better.
It's going to be great. Thank you very much, and don't forget your copay.
Yeah.
This guy goes away. 3 days later, he shows up in my office. I didn't book him. Knocks on the door, comes in. I go, hey man, how you doing? He goes, good. I want to show you something. Knee's got full range of motion. He's got full squat. His strength is back. And I'm looking at him going, oh, that's incredible. You have a knee derangement. And he's like, I got a what? And I go, forget about it. Don't worry about it. You just, keep doing that and see me in about a month. So, out the door goes.
Seen it a million times.
I am so excited. I'm thinking, oh my goodness, there are derangements in the peripheral joints. This is incredible. So I call Robin up, right? Get him on the phone. Hello, Miller. I said, hey, Mac, how you doing? I said, listen, I got something for you. This is incredible. He goes, what's going on, Miller? I said, do you know there's derangements in the peripheral joints? He goes, right. I go, don't give me that Ray stuff, Robin. I said, you do that Ray stuff and it drives me crazy. I said, look, I just discovered something. Hold on a minute, right? What do you mean? He goes, Miller, I wrote all about it in the book. Have you ever read the book? And I'm like, oh man, this is a bad phone call. Why did I do this to myself, right? And so now it's all kind of coming back to me. I'm going, oh no. And he goes, Miller, go get the book. I'm thinking, oh, this is bad. So I open it up. Page 5. He goes, page 5, Miller. He goes, could you read the paragraph? And basically, what it says is, I have developed a system of examination and treatment. I don't think I'm quoting it exactly, but it's like this. Of examination and treatment that not only pertains to the lumbar spine, but you can apply it to the cervical and the thoracic spine, as well as to all the peripheral joints. So according to Rob McKenzie, that was his first peripheral joint book. Right? And then he goes, all right, Miller, don't call me with this again. And of course, he hangs up. I hang up. I'm like, oh, it was one of those, and I don't know if your readers are, if your listeners are gonna be okay. It was one of those oh shit moments, right? And I'm thinking, oh, I got to be very judicious when I call him, right? I got to think this stuff through better. I got to play chess.
Yeah, reflection point there. You look in the mirror and reevaluate your life.
It was a great lesson. It was a great lesson. So let me tell you the second lesson. So I'm flying around Canada and I'm teaching courses, right? And I'm thinking to myself, well, here I am in Timmins, Ontario. There's a lot of clinicians here that really would like a course. Maybe I'll do one here. And so I decide to do one there. And there's 14 people that have decided to come to this course, but the McKenzie Institute Canada says let's do it. So I didn't know at the time. I was pretty young, and I didn't know that the further you fly, the smarter they think you are. Right? But in your own hometown,
backyard, you're an idiot.
You're pretty much an idiot,
yeah.
Right? Exactly. And so I teach this course. I think I do a very nice job. And 13 of the 14 critiques, I'm pretty much an idiot, right? And I was berating, and I asked them to research literature, and how dare I challenge their professional integrity and everything else. I'm reading this, I'm going, oh my God, I'm the wrong guy for this. This is crazy. I'm killing the Institute. I'm killing Robin McKenzie's work in Canada. And I'm thinking, oh, I gotta make a call. I'm done. I'm finished. This is over.
Here you go.
Oh yeah, it's over, baby. Yep. So I call Robin up. And hey, Mella, how you doing? I'm pretty good, Robin. How you doing? And I go, Robin, listen, this is a tough phone call for me, but I want to let you know that I'm resigning. And he goes, what are you talking about, Miller? And I said, well, here's what happened, Mac. I really think you picked the wrong guy. And thank you, by the way, but I'm the wrong guy for this. I said, I just taught a course here in Timmins, Ontario. And
don't read the review.
No, I said, you got to read these. I said, there's 13 of them. They panned me. I said, they panned us. I said, we're done here. And I blew it, man. So listen, thank you. And thank you for all I've learned. And I said, but I really think it's time for me to just kind of get out. And he goes, Miller, he goes, what if we do this? Why don't we take those 13, we'll offer to give them their money back, and we'll tell them not to come back to another course. He says, would that take care of things, and then maybe you'll teach another course for me? And I said, really? And he goes, oh yeah, I think we ought to do that. I think that's a good idea. I said, thanks a lot, man. And he goes, don't worry about it, Miller. good talking to you. And that was it. He hangs up. And I sit back and I go, you know what? I finally realized what kind of a guy this guy is. You know, and then that was it. And then it's been forward and fast and wonderful ever since. You know, the guy gave me an international stage is what he did.
Yeah.
And let's face it, I've had to live up to it, but he gave it to me. And anyway, if you want to know who he is, that's who he is.
Yeah, what an awesome story. Holy smokes.
There's a lot of misconceptions about what MDT is. So we're kind of getting away from a pathway anatomical diagnosis.
That's right.
You do have papers, whether it's Fazzi, Alexander, and Spine, and clinical biomechanics, that do show the disc model actually does occur maybe in the younger spine. Mm-hmm. Can you kind of talk to our listeners about why McKenzie stays away from like pathway anatomical diagnosis?
Right.
But then you also, as you stated today, I mean, you have the reality of there's a certain personality type that does want to be educated on some kind of disc model.
Sure.
So
listen, I'll speak for the McKenzie Institute first. I'll then speak for Robin as best I can, and it's not fair because I'll do the best I can to represent him, and then I'll speak for myself. So the McKenzie Institute, as you well know, is moving away from all models, including the disc model. But I can tell you, it's not happening without a lot of sort of debate and argument and discussion within the organization itself. And the way I understand it at this point is, and again, it's interpretation of what are we doing here as a institution. And it's, you can use the disc model as an explanation to those individuals that you deem as a clinician are going to be best served by it. But what you do not want to do is you do not want to use it universally, and you do not want to treat with the disc model in mind, okay? And I think that's a fair statement. Now, Robin, I asked him about it. I had the opportunity to sit with him and ask him about it. And he said, look, Milla, the disc model is just it's a tissue of best fit. He goes, here's what happened.
read page 6.
You know, read page, and don't call me with that again. Right? Yeah, no doubt. So his point on this was simple. He goes, I've got this guy, Mr. Smith. I put him into sustained extension by accident, which is exactly what Syriac said not to do. It's exactly what I was teaching at Otago University not to do. And he says, and son of a gun, this guy gets better. So what do? I go home, I open up the anatomy books, and I'm trying to figure out what the heck happened. And he says, it was the tissue of best fit. And I said to him, I said, okay, hold on a minute. Let's say the anatomists and the biomechanists and the clinicians of current excitement determine that it's the zygapophyseal joint. That's the source of all of the derangements. And the disc has nothing to do with it. What are you going to do now? And he says, Milla, all we're going to do is we're going to change that 1 hour at the beginning of part A. And instead of talking about a disc model, we're going to talk about a zygapophyseal joint model. That's what we're going to do. And I said to him, I said, come on, man. Don't kid me here.
Yeah, right.
I know that disc is close to your heart. Come on.
Yeah.
The truth. And he goes, I've just told it to you. Would you like another drink? And so where I'm taking you, and this is a true story. We were sitting, I'll never forget it, we were sitting in his living room. And as a diploma guy, he did this with every diploma team that came through. One time, he got invited to his house, and it was a wonderful time. And his wife was wonderful. Joy's great, and we had a great time. But I challenged him on that because I was curious what his thoughts were, and he was very clear. It is a model. It was a tissue of best fit. It is a nice explanation, and I have no clue if it's correct.
Do you feel in saying that you can get as much buy-in from a patient for exercise compliance with a certain movement helping an arrangement versus when you draw out that beautiful disc model? Like, do you feel like the compliance is the same if we're being honest with each other?
Right. And the answer is absolutely yes and absolutely no. And it really depends on who that patient is. It depends on their thought processes. And now, because of the way we think of things, it's their healthcare beliefs, right? But if you go back, and let's forget all the new stuff about motivational interviewing and the biopsychosocial model, and let's just go back to just practical, which is your question was a practical question. The answer is the disc model is the best thing to show them, or it's the worst thing to show them. It depends on who they are, what they think, what their training is, what they've been told by other clinicians. Do they trust a clinician that they just spend time with, or do they think that clinician's crazy? And so it really comes down to, you have to be sitting in front of the patient and you got to go, disc model or no? Which way am I going to go? That's right. You know, the pain people now, like the pendulum keeps swinging. You guys know this. You've been around forever, and you're recognizing as well around the country and perhaps around the world. And you know the pendulum keeps swinging, right? So, and the pendulum now has kind of swung more towards the pain guys going, whatever you do, don't use a visual analog scale. Don't use a numerical pain scale. Don't talk about anatomy. Well, guess what? They are absolutely correct, except for when they're wrong. Mm-hmm. And that's kind of the way it is. So you're sitting in front of a patient. You've seen the cause and effect action happen. You've seen the leg start to improve. You've seen the tension signs start to improve. The extensor hallucis longus is actually starting to behave like it might. And you got to choose. Do I use a disc model or not? And sometimes I do. Sometimes I don't.
Yeah.
So,
well, I think that's a pendulum that we talk about a lot on this podcast, is that it seems like the pain science, if you follow that, you follow the pure literature, the evidence base, you're not doing anything with the patient. So you're slapping them on the butt and saying, you're going to be just fine.
Yeah, you put your arm around them and you say, it's going to be great. Unless, of course, they operate on you.
Yeah, exactly. Then it was their fault, not mine, right? So
now, am I allowed to try this new bottle?
Let's go.
Guys.
We're kicking out of the Chapelet. Come on. Well, I think that's a great kind of a stopping point or a next mixing point of
Can I add one more question before we go to IMC? So today, I thought you gave a great analogy. You're talking about Susan Mercer and how, like, she was an anatomist, and she was talking about, like, kind of a fat pad model in the peripheral joints. And I thought that was interesting. I never even thought about that. To me, it was always, I was thinking cartilage fragments, or I was thinking, meniscal, So maybe in the peripheral joints, we don't exactly have a disc model, but then we perhaps have another model that potentially we could educate the patient on.
Sure.
Since you're kind of the leading expert in the world in MDT for peripheral joint treatment, can you kind of comment on, although we don't have an official nucleus pulposus in our extremity joints, could you elaborate on that for us, please?
Let me do this first. I think your description of me was very generous. However, hey, you know what? Call my wife and let's go with this.
Talking about being experts in your own backyard, we always say, like, treating your wife, you know nothing.
No,
like,
you
concentric circles away from that, you become...
I tell you what, if you try to treat your wife, you've proven to me that you do know nothing.
That's a road to nowhere. I mean, every time.
What were you thinking?
Yeah. I'm more, this hurt!
Congratulations, you are definitely an expert, in your own mind. Because you might have wanted to avoid that.
I've done this 1,000 times. No one's ever said anything, and you're like whining about, it's like, come on. All right, back on track.
No, sorry.
My wife's going to come after this.
We digress.
They don't mess with us anyway,
right.
so we'll cut that
out. By the way, my wife will actually appreciate that because she has had a long stand. It's funny. She goes, you can fix everybody else, but you can't fix me, can you? So you've all been there. We all know how it works.
Did you go biopsychosocial on her or not?
Yeah, that's right. I'm going now lately with the motivational interviewing. Right. You know what? She knows what I'm doing.
Yeah.
She figured it out. It is not working.
Smiley faces. So how do you feel today?
Yeah. Truly
proud, happy.
Maybe try to dig into your healthcare beliefs. So, okay, I'm sorry, guys. I know
we digress. Our peripheral joints. Yeah. That fiscal. What is it?
All right. So here's the deal. Patients need something to grasp onto. They need a model. They need something. And so the model that I gave you today, and that did not just come from me. There was a bunch of us. Herbawi was one of them. Colin Davies up in Canada. But we took Susan Mercer out for a couple of drinks, and here's why. She had just published a paper. And by the way, if you ever get a chance, and I don't even know if she's still on the circuit at all. And I've heard a couple of social stories. She's a wonderful, wonderful person. Her intellect is incredible. And she's always excited because she's an anatomist, right? So, I'll give you her quote. When an anatomist has an opportunity to see there's a possibility that their findings have clinical application, That makes us giddy. That is our mind blower. And so when we approached her at that particular conference that you're talking about, she was so excited to just sit down with us. Now, the Sauvignon Blanc didn't hurt, right? But she was so excited. And the second part of the story I didn't tell was 3 weeks later I get an email from Colin Davies, because Colin Davies said, he's the classic, give me your contact information, I'll stay in touch with you. And he emails me, he says, Susan Mercer was wondering if maybe she could come down to Austin, Texas and watch you examine peripheral joints. It's like, are you kidding me? That would be a yes. Right?
Let me think about it.
Oh, okay, yeah, she can. Yeah, tell her to bring some wine in. Right? So anyway.
Try to play cool. Like,
well, there's no big deal for.
Let me check my schedule.
And that's exactly it. So anyway, what happened was this. We were seeing these, obviously, derangements in the peripheral joints, and we didn't really have explanations. Like you said, there was no disc model. So what was happening, and I was along the same pathway as you. Obviously, something is hurting. It's something in the way. But the problem was this: not only did it have to be in the way, but it also had to cause pain, right? And the little cartilage pieces and things made sense about being in the way, but then the question was, okay, how did that become a pain generator? Well, I was making stuff up. I was just telling patients, you'll love this, and I wish you guys could see the diagram. I'll never forget the first time I had a shoulder derangement, and the woman goes, so that piece you were talking about, where did it go? I was going, this is not cool. Yeah. All right, so now go back to shoulder anatomy. If you remember, or I made it up, I can't remember now. This is either the truth or I'm just lying. But if I remember in my anatomy, there was a little appendix on the shoulder capsule, kind of came down, right? And so I drew it for her, and I said it goes down in there.
That's called pathoanatomical diagnosis.
No, thank you very much. This is a true story, by the way. You're not going to believe this, but it's a true story. And she goes, how does it stay there? Right? And I said, gravity, so never stand on your head. It's a true story. And she kind of chuckled. And she goes, okay, I won't. At that time, that was my prophylaxis program for shoulder derangements. Stay off your head. I'm not kidding.
Unreal.
That was a true story. So anyway, so Susan, fast forward, I know we're digressing here, but so Susan Mercer's paper, the first one that I had read, no, it was the second one. The first one, she had a disc thing. But the second paper that I had read of hers was about elbows. And all it was what she called elbow inclusions. And what she described were these fat pads. And these fat pads were all throughout the elbow. And in her discussion, it was just an anatomical description of them. Some of them were just fat pads and they all had innervation. And if you think about it, well, how could that happen? Well, for fat to survive, it has to have blood. Blood never goes anywhere without nerve. They're combined, right? So she described that, and then she, at the very end, she just said, it's possible that maybe these fat pad inclusions that I'm describing could be reasons why people have elbow pain. That was it, right? So I remember reading this and a few of others, and I don't know how the whole thing evolved, but one of us or some of us said, I wonder if those are elbow derangements. So she was speaking at a conference. We're all there. We said, hey, could we talk to you a little minute? And we said, we're really excited because we're seeing these elbows that change rapidly, and we're thinking maybe that your article's got something to do with it. We were wondering can we talk to you? And she was like, are you kidding me? I'm an anatomist. If there's clinical application, let's go. So we go. Well, this lunch went on for like hours and hours and hours. She started pulling up all these dissection slides of shoulders and knees, and she's showing us all these fat pads that are all over the place. And we're picking her brain like crazy, right? We're like, well, how long do they take to develop? And where do you find them the most? And here's a couple of things that we learned from her. She said, people who had trauma in their history had more than those that didn't. People that had more degeneration had more of them. And I'm convinced, based on the analysis of the cells, that they don't take long to develop. So I'm like, whoa, those could be the answer to derangement. Now I got to be clear here. The McKenzie Institute is like, we're not using that as a model. Robin never wanted to have a model for the peripheral joints because he was afraid that people would all of a sudden start treating the model like they did initially with the disc model for the spine. And it was like, it drove him crazy, right? He's like, the disc model is a description of what I'm seeing in the clinic, and I don't know if it's right. Mm-hmm. See what I'm going? So he wouldn't go for a model for the peripheral joints. But I started using it, and a couple of the other guys started using it, and the girls started using it, and I think a lot of the faculty do, but you know what, I can't speak for them because I don't know. Mm-hmm. But I use the fat pad model all the time. Yeah. And it came from Susan Mercer. So you're going to love this story. Well or not. Are we taking up too much time here?
Oh, God.
Oh, my God.
Oh, okay, good.
Let's get loose, bro.
We got a bottle of Chapelet here.
Yeah. So anyway, Susan Mercer calls me up and says, can I come to Austin? So I was like, yeah, that'd be a good idea. That'd be great. Why don't you, I don't know, do you got a place to stay? And so she says no. And I said, do you want to stay with us? So she's like, yeah, I'd love to stay with you. So I pick up Susan Mercer at the airport, and she's staying at our house.
How amazing.
And I'm going to like, Susan Mercer is in my guest room. She's not sleeping. I got questions. And so, I'm like, I can't believe it.
5 a.m.
No. It's time to go to bed, Mark. So it's like I got Susan in our house for like 3 days. Yeah. It was awesome. And she's a great lady, just absolute great lady. But I'm picking her brain. But one of the things she wanted to see us examine peripheral joints. Well, Scott Herbout was my partner at the time, right? And he was teaching a course that day. He couldn't believe it. So I was like, he's gone. And I got Susan Mercer all myself, right? And so I called all the physicians I knew in town. I said, send me these peripheral joints. 9 peripheral joints in the morning. 9 we got. And I examined every one in front of her. 7 peripheral joint arrangements.
Oh, you got lucky, baby.
Yeah. 7.
Yeah.
No spines. 7. Never in a million years is this ever going to happen. And as it's happening, I could just see her wheels spinning. And then she starts asking these patients, do you ever get pain right here in your elbow? And they go, that's where it is. That's the pain. There's a fat pad there, Mark. There's a fat pad. I find a fat pad there every time. she's like losing it because she's an anatomist and she's seeing a clinical application, right? So ever since that experience with her, I've used the fat pad model. I don't, in a derangement in a peripheral joint, I use it with every patient. And they see it, it makes sense to them, and I can tell you it garners compliance. And so that's how I do it. For what it's worth to your audience, it's up to them. Yeah.
For our listeners, we were with Tom Michaud this past week in Boston, who's basically the world's expert in foot orthotics, human locomotion, etc. But anyways, he said, if you ever get a hold of like a researcher, he goes, they will treat you like a relative because they're not used to people. They're like, someone actually read my stuff. Like that, they're like so blown away and shocked that. So sounds like Susan Mercer, we can put her in that category. Is she's enamored with the actual clinical application.
Absolutely.
Sounds like we got a trip planned.
Yeah.
Well, you guys are going to love this. She married a guy that owned a winery in Australia.
Oh, let's go.
And
can we go tomorrow?
I'm telling you.
In?
I'll find out for you.
You're in.
You know what?
IMC private jet? Let's go.
Yeah, you know what? If you could get a bicycle across the ocean, the IMC bicycle would get you there.
Start somewhere.
But I tell you, if we're successful, and I don't rate success in terms of how much money you make. If we're successful because we create the change we set out to, there actually might be a jet. I'm a little embarrassed and I'll never use it. All right, but it might be there for you.
Sew it on a pillow. How about that quote?
Cool.